Hi, everybody. Thank you so much for joining us today on Thursday as we go to our, USMLE live video that we have been doing for the past couple months. Today, as always, we're joined by Dr. Roland Zhang. Hi, Roland. How are you?
Good morning. Thank you for having me back.
Of course. Thanks for, joining us on your vacation. And where are you again?
I am currently in Morehead City, North Carolina.
Oh, very nice. The USMLE does not stop for vacations. And we are also joined, we're also joined by our wonderful guest student, Majd. How are you?
I'm good. I'm glad to be here. Thank you for having me.
Of course. Thank you so much for joining us. So you're a fourth year St. James medical student, correct?
Yes, correct. I'm here in Chicago right now.
Oh, cool.
Doing my last four elective rotations.
Very cool. Very cool. So do we want to hop into this week's question, Dr. Roland?
Yes.
Yes, sounds good. So once again,
Okay.
what day is it? Happy Wednesday. Thank you for joining
Thursday.
us. Here we go. Thursday. Happy Thursday. So today's objectives, like always, what we're doing today, we're going to go over the question. Well, not me, our awesome student, Dr. Mez, will be doing that, going to risk factors, etiology, the pathophys, etc. He'll then go over the wrong questions. And then at the very end, we're going to try something different today. So I call it the TLDR. They're too long, didn't read. And my thoughts are that if I was a busy medical student, what do I want to hear, what do I want to read, what do I want to see in a very short amount of time, right? As the garbage truck goes by.
You're fine.
Sorry about that. And then, so in a very short amount of time, what do I want to hear from a medical student perspective? I would not want to watch a 10, 15-minute YouTube video about this. Just give it to me straight. So at the very end, we'll be testing that out. If you like it, fantastic. If you don't like it, yell at Megan. So, student Dr. Mez, ready?
Yes.
Here we go. All yours, sir.
Okay. All right, I'm going to start with reading the question, and then I'll give you guys time to think about, your answer, and then we'll break down the question together. A 55-year-old woman comes to the emergency department by ambulance for sudden right vision blurriness. She also has associated headaches, fever, and muscle pain. The patient was planting vegetables in her garden when the symptoms developed. She denies any similar previous episodes or any recent trauma. She has experienced jaw pain when eating and talking over the past few weeks. The patient has tenderness of the temporal area. Laboratory evaluation results show a significantly elevated erythrocyte sedimentation rate. So which of the following diseases is most probably associated with this patient's diagnosis? So now I'm gonna give you guys, you can, if you know the answer, you can go ahead and message it to us or comment below. So now I'm going to go ahead and break down the question, at least in the way that I go on about questions. I first read the actual thing they're asking of us, the question. So I'll be like, which of the following diseases is most probably associated with this patient diagnosis? Because now I know what I'm looking for in the, in the vignette. So as I'm going through the vignette, the first thing I notice is that the age, and then that she's a female. So they're giving me two clues there. And then by them saying that she's going to the emergency department, that tells me that it's an acute issue and maybe not a chronic problem that she's having. And she's also coming in for right vision blurriness. So we know that she's having some visual changes. And then when I read the second sentence, I see that she has a headache, fever, and muscle pain, very generalized symptoms that I don't necessarily need to worry about too much about right now, because it's not giving away any direct differential diagnosis. And the second one, she's planting vegetables in her garden, doesn't tell me much. She denies any similar previous episodes, again, doesn't tell me much. And then the fact that she's experiencing jaw pain when eating and talking, that gives me a clue here to what this patient has. And then the fact that she has tenderness over the temporal area with the fact that she's 55 and she's a woman gives me a lot of information here to know, to come up with a specific differential diagnosis. And then the fact that she also has an elevated erythrocyte sedimentation rate. But if you guys know the answer, please comment down below. And we're ready to go to the next slide. So if you did not know, the patient presented with giant cell arteritis, or otherwise known as temporal arteritis. And in these images, you can see what an inflamed temporal artery looks like. Usually the patients that will present with these symptoms and this disease, you'll be able to visualize and even palpate the temporal artery. And we can go to the next slide. Okay, so giant cell arteritis is basically a part of a group of diseases or autoimmune diseases that affect the vessels. We have small vessel disease, arteritis, we have medium, and we have large. And giant cell arteritis happens to be part of the large vessel vasculitis group. Its name kind of helps you remember that it's part of the large vessel vasculitis. It's basically it causes chronic inflammation of large and medium-sized arteries, specifically the aorta, the carotids, and the carotids branches. You on exam day or during your, on exams, you will most likely see it being present with the carotid and carotid branches, not so much the aorta. And we're going to go over the risk factors next. Mostly it's seen in females at the age of 50. But it peaks at the age of 70 to 79. But for exam day, you need to know that it's age 50 and above. It's usually a Caucasian female of European descent. And the patient will have 50% of patients with polymyalgia rheumatica have a chance of developing temporal arteritis. And that is the answer to the previous question that we just went over. Etiology is unknown, but there's possible genetic contributions that we've linked to temporal arteritis. Scientists have studied the human leukocyte antigen, HLA-DR4, and it's linked to temporal arteritis. And some also think that viral infections can even trigger temporal arteritis, like parvovirus B19. And you'll see that association when we go over the pathophysiology and how this disease develops. So pathophysiology, basically, you have dendritic cells that are activated. And once they are activated in the outer layer of the artery, which is the tunica adventitia, they are going to recruit and call over Th1 cells, CD8 T cells, and monocytes. And once these cells are activated, the monocytes will differentiate into macrophages and giant cells, hence the giant cell arteritis. And they will produce cytokines like interleukin-6 and TNF-alpha, which are precursors to the inflammatory response. So basically what they're going to do is they're going to call over more inflammatory cells, and they're going to aggregate together. And that's where we're going to see the focal granulomatous inflammation. That's a hallmark for temporal arteritis. And then the intima, which is the inner layer of the artery, will become thicker through hyperplasia when the macrophages and giant cells aggregate together, and they will also produce growth factors, and that will reduce the blood flow and even sometimes just completely occlude the artery. And depending on which artery is involved, you might have vision loss or a stroke. Okay. So this in this slide here basically just goes over what we just spoke about in the pathophysiology, how the dendritic cells in adventitia will call over the monocytes and Th1 cells and the CD8 T cells, and how the interleukins play a role, and how eventually in the intima you're going to have the the hyperplasia or the stenosis of the artery. And in this slide here, just basically goes over the same thing. This is just in more detail. And now we're going to go over some symptoms. The first set of, I separated the symptoms in order of like how important they are to this disease. The first set of symptoms, you're going to see fever, weight loss, night sweats. You'll see fatigue, myalgia, and arthralgia. But these symptoms, the reason I didn't highlight them in red is because they're not very specific to the disease. So you You will see them and they will help you make the diagnosis, but it's not very specific. They're very generalized symptoms. The symptoms in red, which is the headache that's typically over the temporal sides of the head, the hardened and tender temporal artery to palpation, the jaw pain when chewing, the vision loss if the ophthalmic artery is involved. Those are very specific to temporal arteritis, and they will help you make your diagnosis. And then the last part is not high yield for the exam, and you might not even ever see it in the exam, but in real life you might. So the giant cell arteritis can also affect the aorta, and when it does, you'll have chest pain, abdominal pain. You'll also have asymmetrical blood pressures depending on which artery is occluded, and you also have features of abdominal aortic aneurysm, but they're not very specific. They're not very high yield symptoms. And now we're going to go over the diagnosis. I just want to say this at the start, is that in order for you to make a diagnosis of temporal arteritis, you must have image or biopsy confirmation of the cell, of the artery, and seeing that there's the changes that you need to see. And this might not be high yield for step one. I don't think you need to know that you have to have a biopsy or image. But in labs, you're going to see an elevated erythrocyte sedimentation rate, as we also saw in the question before. You also see elevated CRP. And then in order for you to make your diagnosis, you have to do the temporal artery biopsy, which you can see I mentioned that it's a gold standard for confirmation of the disease. So in all patients that you suspect to have giant cell arteritis, you must do the biopsy. But sometimes there can be a false negative because of skipped lesions. So like the artery is, long, and if you take, one part of the artery and then it might look normal, you cannot say definitively that this patient does not have giant cell arteritis because the part that you took could be a skipped lesion where everything looks normal. Okay. So then you would want to move on to do imaging, and you use ultrasound because that's the first line imaging for giant cell arteritis. And you would see edema and thickening of the vessel wall, which they call the halo sign. You also might see stenosis and occlusion, and that can help you make your diagnosis. And this is what a biopsy would look like under a microscope. You can see 3 layers of the artery, and they're all inflamed. And then you can see the intima is completely closed off, and there's stenosis. These are the wrong answers. I'm just going to vaguely go over them. In terms of this question, you just need to know that the patient had, giant cell arteritis, and then the polymyalgia rheumatica was the only, disease that was associated with it. And the fact that she was a 50-year-old female can tell you that, because polymyalgia rheumatica was a 54, around a 50-year-old female. She's going to be older. It's going to be a female. Whereas ankylosing spondylitis, even if you didn't know that polymyalgia rheumatica was associated with giant cell, you can, with this knowledge, you can use to figure out which one is the answer. Because ankylosing spondylitis is going to be a male, and they're going to be around 25 years old. Fibromyalgia is going to be around a 30-year-old female. So again, the cutoff for the age can help you, make your answer choice. We can go to the next. Okay, so now this is the second part of the question. Which of the following is the most appropriate treatment for this patient's symptoms? And you can go ahead and make your answer known in the comments. We can go to the next slide. All right, so treatment, you want, for step one, all you need to know is that high dose glucocorticoids, usually prednisone, is the correct answer. And you don't need to know much more than that. But high dose glucocorticoids for 2 to 4 weeks is what they put the patient on. And then after that, they will taper them down to a lower dose. And that usually can go on for longer than 2 years. And you want to start the patient right away on glucocorticoid therapy, and that reason is to avoid stroke or vision loss, because once you lose your vision, you might not be able to regain it. And then once, so basically, like I said, you want to initiate the diagnosis before before you even come up with like a definitive diagnosis, if the patient has a high risk probability through their symptoms to have giant cell arteritis, you want to start treatment to avoid so you can avoid vision loss or stroke. And then in severe cases, you might want to do IV steroids, and that usually involves a pulse therapy with methylprednisone. And in patients that cannot tolerate long-term steroids, you want to do a different, route of treatment, and you're going to use like immunosuppressants basically to suppress the immune system so that the inflammation isn't as bad. And you'd use teclistamab or methotrexate. And now I can hand it over to Roland, the boss.
No, that was amazing. Thank you so much. So here's where we kind of do like one giant summary. Please forgive my puppy for going crazy. So if you take away just one slide, and once again, thank you so much for an awesome presentation. This is the kind of slide that I would appreciate. The fact that let's go over the whole thing really quickly in a nutshell. So like Dr. Mej was saying, is it autoimmune vasculitis that affects the large immune-sized arteries, particularly the carotid arteries. One question I saw in the step 1 prep was the roots of the carotid arteries. So which one actually feeds into the temporal arteries? We're gonna have puppy for dinner. So it's most common over the age of 50 and Northern East European descent, like Mesh was saying. And approximately 50% have polymyalgia rheumatica. So earlier he mentioned the fact that you want to do an ultrasound compared to a temporal biopsy, which is completely true. So when do you want to do an ultrasound if the biopsy is the most accurate, right? Well, the fact that if the patient is relatively healthy, they don't have a temporal arteries as a whole, maybe we can do a ultrasound and spare them of actually drilling into the temporal artery. So if they don't have these severe symptoms, maybe we can do an ultrasound. If they do have severe symptoms, we'll do the prednisone, like a student Dr. Mesh mentioned, and then we can retrospectively do some imaging. So long story short, look at the question. What are you trying to say? What's the most accurate? What's the quickest? Which one's the gold standard? These are 3 really simple ways of making a question a little bit more challenging. Sorry. So they also present with B symptoms. So fever, weight loss, night sweats, new onset headache, tender hardened temporal artery, jaw claudication, and amaurosis fugax. If you ever see a term or a medical term that you don't know, look it up. So Medj actually mentioned both of these: jaw claudication, jaw pain upon chewing, amaurosis fugax, so loss of vision, either one eye or both eyes. So if you have a strong suspicion, you want to give him a steroid. He didn't mention the fact of IV compared to oral. So if you don't have organ damage, you can give oral steroids. If you do have the sudden vision loss, you want to really dose them quickly and very strong dose, so the IV steroids. That could be a potential question as well. How bad are they presenting? If they have the sudden vision loss, hit them with the IV steroids. If not, you just kind of found it accidentally or found them retrospectively, you give them the oral steroids, have a little bit more time to treat them. Lab studies show inflammation, and like student Dr. Mesh mentioned, elevated ESR, CRP, biopsy imaging, depending how quickly or how rapidly you want to find out. But if you clinically suspect it, hit them with the steroids. Right? Classic histopathological findings, so classic histology questions, show the giant cells and follow to rheumatology, because most of them need around 2 years, like Mesh mentioned. So overall, very well done indeed. So thank you everyone for attending. At this time, I want to ask Mesh, having taken step 1 and done very well, what is your gold standard? If you give one piece of advice to all our wonderful students, what would that be?
Honestly, if I had to go back in time and give myself advice, I'd say discipline. Just sit there and do 6 to 7 hours of solid studying, like quality studying a day, and I think that should be enough. Maybe over a period of like 2 months, and that should be enough for you to pass your step 1 and do really well. But definitely discipline, and it doesn't matter what time you wake up, doesn't matter what time you go to sleep, as long as you just get 6 hours of solid studying a day.
I completely agree. If I can have one caveat, a study with the plan, right? It doesn't help anyone just studying 67 hours, grinding out, but have a plan. Like, are you focusing on organ systems? Are you focusing on subject? What is your to-do list of the day? And then put in time. So have your plan, then put in discipline, like student Dr. Best mentioned. Well, that's it. Thank you so very much. Ms. Megan, anything that we forgot to cover?
No, I think you all did a wonderful job of going over this question and kind of breaking it all down for all the students and everybody who's watching. So thank you so much.
Yes, thank you guys for the opportunity.
Yeah. Thank you, everyone. We'll see you in 2 weeks.
Yeah. Bye, everybody.
Right. Bye. Have a good one.